Okay, thank you, Dr. Maligi, for the introduction. I'll discuss the evidence-based concepts in the diagnosis of erectile dysfunction. Why is this important in ED diagnosis? Unfamiliarity with the concepts of evidence-based medicine leads to diagnostic errors, serious medical, psychological, and social consequences. This is a big deal we have in Egypt and most Middle Eastern countries, and probably many other countries around the world, because we see a large group of young patient populations within the 20s and 30s who present with erectile dysfunction. A lot of it is related to anxieties and sexual ignorance and lack of sexual education. So let me present this short case. It's very common that we see within our daily practice in Cairo and probably many other countries around us. A 24-year-old male, married for 2 years. He has erectile dysfunction of 3 months duration, which is of a sudden onset and intermittent course. He has good morning erections. He has no risk factors like the ones that Dr. Anis just discussed. No diabetes, hypertension, dyslipidemia. He's not a smoker. And a penile color Doppler test shows an elevated end diastolic velocity. A cavernosometry diagnoses venous leak. So does anybody around here really believe that this guy has a physical disorder for his erectile dysfunction? Yeah. Would anybody believe that this guy really has venous leak? Okay. Nobody believes it. Unfortunately, we see such cases almost daily, and a lot of them are advised to undergo venous surgery or penile implants. So how come these tests are turning, these tests were done properly, so how come we are getting these false positive results? I just want to remind you of the 3 pillars of evidence-based medicine, which are clinical experience, patients' preferences and values, and having the best research evidence available. To assess a performance of a diagnostic test, we need to know its positive predictive value. This is the most important element, and I'll highlight it later. The sensitivity and the specificity of each test, the negative predictive value, and the likelihood ratio. It looks complicated, but it's quite simple. Let's take a population of 100 patients and assume that 4 of them have the disease, let's say a venous leak, truly venous leak. So the prevalence of the disease would be 4%. What about the test that we've done? If the test detects venous leak, for example, in 3, then the sensitivity of the test is 75%. And what about the specificity? We are assuming a 7% false positive result. So the specificity is 93%. So far, things don't look that bad. But when we look into the positive predictive value, we would find that only 3 out of 10 positive cases really do have the disorder or the venous leak. Let's assume that. So the positive predictive value of that test is only 30%. This highlights the importance of the positive predictive value as a diagnostic test, or as a diagnostic criteria. In such a situation, the negative predictive value would be 99%, so it's a good negative test. What about the likelihood ratio? This concept has been applied in other areas of medicine, in chest and cardiac and cardiology generally, but not in sexual medicine, which we needed. Likelihood 1 is the likelihood that someone with a disease tests positive. And likelihood 2 is that someone without the disease tests positive. The ratio between them is the likelihood ratio. We don't need to know the calculations, but generally knowing the likelihood ratio of a disease would let us know the post-test probability, or what are the chances of that patient carrying the disease after we run the test. So has evidence-based medicine been applied to sexual medicine? In treatment, certainly. There are numerous randomized controlled trials with PDE5 inhibitors. In the diagnosis, certainly not. And I'll come and show you now. First, do we need an etiological diagnosis when we treat ED? Usually, if we follow a goal-directed approach, we don't. We just start one step of treatment after the other. However, for many patients, especially in young men, knowing that the condition is reversible is part of the therapy. And the association of certain types of ED with life-threatening conditions like arteriogenic impotence has been shown to be associated with coronary artery disease. That's an important association. So a test with false positive results could lead to serious psychological setbacks, especially in young newly married men who are told that they need surgery, for example. And frequent false negative results might miss a potentially life-threatening condition. So how can we diagnose psychogenic ED in a young man? Well, I've placed this question on the discussion list of the International Society of Sexual Medicine. And all the responses that we got were based on opinion and common sense, but none on research evidence. So far, I will prove that we don't know, or we cannot use our investigations to differentiate between simple psychogenic and physical ED. For example, Dr. Sidney Galina's opinion, which I agree with, is that young men with ED but with rigid morning erections and normal nocturnal penile tumescent testing are unquestionably psychogenic, and that cavernosography, cavernosometry, and color Doppler tests that rely mainly on obtaining maximum smooth muscle relaxation are highly influenced by the anxiety and the adrenergic tone causing vasoconstriction. That's why you are getting a lot of false positive results with these tests. Dr. Hartmut-Post's opinion is that to diagnose venous leak, we need certain criteria, which are no episodes at all of completely rigid erections while performing sexual activities, and no complete erections after maximum dose trimix injections intracavernously. Dr. Pierre Asselian's opinion is here. You see that ED should be situational and high levels of performance anxiety should be elicited. And Dr. Moser's opinion is that it is rare to see a pure case of either psychogenic or organic erectile dysfunction, and the diagnosis is usually multiple etiologies. Well, this is not the case in the Middle East, since we're seeing a lot of young men with erectile dysfunction. So what we conclude is that you don't have a gold standard diagnostic test or protocol to differentiate between psychogenic and physical ED. The main questions that we need to answer really there is not whether it's psychogenic or organic, is that does the patient really have ED and what is the severity, and we can obtain that with a proper sexual history and validated questionnaires, and what is the etiology and risk factors that could be obtained with the onset course duration and of the disorder, the morning erections, exploring risk factors, a focused physical examination, and the lab tests, a standard lab check for lipid profile, fasting blood sugar, liver and kidney functions, and a CBC. And then selected diagnostic tests as needed. But I would like to highlight that Melman in 1995 reported that there's a 95% sensitivity of history and physical examination alone in diagnosing whether this is a psychogenic condition. The main ED diagnostic tests that we have are the questionnaires, the night erection monitoring, the penile color Doppler, cavernosometry, cavernosography, and the neurological testing. The Regiscan, or the night erection monitoring, is a really good test if the patient gets one episode of 70% rigidity that lasts for 5 to 20 minutes. We're sort of comfortable that this is a psychogenic problem, although that there are opinions that suggest that the pathways, the neurogenic pathways for sexually stimulated erections are different than those from night erections, but at least we know that the circulation is intact. The penile color Doppler is an excellent test that has been tested against a gold standard, which is the arteriography, and we could be pretty certain that the arteries are normal when the peak systolic velocities are high. However, when they are low, they could be falsely low with anxiety, and that has proven through several investigations and several papers. And a high end-systolic velocity is frequently elicited in normal young men, and we don't know the positive predictive value of that test in diagnosing venogenic impotence. The cavernosomography and the cavernosometry gives us very nice pictures. If they're normal, we're pretty certain that they're normal, but if they're abnormal, the patient could still be anxious. And in a study, it was a master's degree thesis in Cairo University, we found that 40% of our normal volunteers tested positive for venous leak. So obviously the positive predictive value there has not been studied, and I don't expect it to be good. These are the main benefits and limitations that we've just mentioned. I will not go through them again here. So the final remarks are that modern evidence-based concepts needs to be applied to ED tests. Mainly the positive predictive value and the likelihood ratio of each test need to be assessed. After we run a test, we need to know if it's positive, what's the possibility that this patient really carries the disorder. A detailed medical and sexual history and a focused physical examination will diagnose 95% of cases. And a stepwise approach to treatment will avoid unnecessary expensive and invasive procedures. So thank you. This is the campus in Cairo University where Obama gave his speech recently. Thank you.